Okay, so let's start with the cardiovascular system of the book First Aid for USMLE Step 1. Just a minute. Okay, let's start. So first we come to the embryology of cardiovascular system. So we'll look into the heart morphogenesis. So it beats spontaneously by week 4 of development. Okay, so what happens during the development of heart? So first there is cardiac looping. The heart tube loops to establish left to right polarity, which begins at week 4. So there are some defects which causes which can lead to dextrocardia. For example, one is cardiogenic syndrome, where there is defect in left-right dynein, which is involved in the left-right asymmetry. Hence, because of defect in this part, there is dextrocardia. In addition, cardiogenic syndrome also have situs inversus. It also shows infertility, like that. Okay, so next we come to the septations of the chamber. First, as you can see, the septum primer goes towards the endocardial cushions. So this is the endocardial cushion. Okay, so septum primer goes towards it, and hence the ostium primer is getting narrowed. Next, in the second step, the ostium secundum forms in the septum primum. Okay, so like, because there is destruction of some cells in the septum primum. This was septum primum is growing like this, and in the septum primum some part due to cell death, there is this regression of the ostium primum and ostium secundum forms. Next, in the third step, the septum secundum develops on the right side of the septum primum. This is another septum. Okay, so it forms on the right side, and this ostium secundum, it continues um, the right to left shunt. Okay, from beginning only there is right to left shunt. So after this, the septum secundum expands, okay, and covers most of the ostium secundum, and the residual foramen is the foramen oval. Okay, this is the foramen oval, small part. So hence the remaining portion of the septum primum forms the one-way valve of the foramen oval. Okay. This blood can go there, but it cannot go back because it works as a valve. Okay, so one more thing we learn here is that there can be like after all this, the septum primum closes again. It's the septum secundum, and so the foramen ovale is sealed soon after the birth because the left atrial pressure rises more than that of the right atrial pressure. So this pressure keeps it shut and slowly it fuses. Okay, it ultimately fuses in early childhood or infancy, and together all this forms the atrial septum. So if there is a failure of septum primum and secundum fusion after birth, which is as told here, it is seen in 25% of the population, which are mostly asymptomatic, but it can lead to paradoxical emboli. What it means is the venous thromboemboli enters the systemic arterial circulation through right to left shunt. Okay, so if there is patency, a venous thromboemboli coming from uh, the venous system, it can pass through it and causes like enter the systemic arterial circulation. Okay, so next, this was mainly about the atrium. Next we come to the ventricles. So the muscular interventricular septum forms, and this this opening is the interventricular foramen. So the aorticopulmonary septum rotates and fuses with muscular like septum to form the membranous interventricular septum, and hence it closes the interventricular foramen. So there is rotation and fusion, and hence in the third step we see growth of endocardial cushion separates atria from the ventricles. Okay, sorry, and hence it contributes to both atrial separation and membranous portion of the interventricular septum. Okay. So this part, membranous interventricular septum, if there is ventricular septal defect, most common congenital anomaly occurring in membranous septum. Okay. This is the part most commonly due to which ventricular septal defect occurs. If there is atrioventricular septal defect, also known as endocardial cushion or AV canal, which is actually associated with Down syndrome. It is very important, and also maternal diabetes and obesity. So this is the acyanotic congenital heart defect with common AV valve plus either the atrial septal defect alone or both ASD and VSD. Now we come to the outflow tract formation. So the neural crest cell migrates, reaches the truncal and the bulbar ridges, it's spiral and together fuse to form the aorticopulmonary septum. Okay, so let's talk about this. Hence it becomes the ascending aorta and the pulmonary trunk in later stages. Okay, so there are some abnormalities like TGA, transposition of great arteries, tetralogy of Fallot, and persistent truncus arteriosus. So um, these are conotruncal abnormalities which are associated with failure of neural crest to migrate. So there is incomplete migration or defective outflow tract formation, hence such diseases. Next, there is valve development, the aortic or the pulmonary is derived from the endocardial cushion. Okay, as we just saw here, it will later form parts of the ascending and uterine pulmonary tract. And mitral and tricuspid, they are derived from fused endocardial cushions of AV canal. Okay. So it is formed by outflow, the aortic and pulmonary, and mitral by the AV canal. There are some valvular abnormalities like stenotic or regurgitation, or mitral or tricuspid regurgitation, or atresia also, or it is displaced like Epstein's anomaly. Epstein's anomaly seen I think it is seen in it's a congenital disorder. Okay, let me check. So yes, so it is related to lithium exposure. Okay, so like mothers who are receiving lithium due to bipolar disorder or like that, if they are exposed during the first trimester, it can cause Epstein anomaly. And there are some unknown causes also of this. Okay, next, coming to the next part, there are some structures, the embryological structures, what it give rise in the future. Okay, so right common cardinal vein and right anterior cardinal vein, they together form the superior vena cava. Okay, so these are the cardinal veins, right common and the right anterior cardinal veins. Okay, so this superior vena cava, then the posterior cardinal and subcardinal and the supracardinal veins, they give rise to inferior vena cava. Okay. So actually, for example, you see there are embryologically there are two. Let me show you. Okay, so suppose this is the anterior cardinal vein and this is the posterior cardinal vein. Okay, so what happens, there are a lot of like changes, but let me show it again. Okay, so what happens, is the right anterior cardinal vein, right sided. Okay, right left, right anterior cardinal vein, and the right common cardinal vein. This is the common cardinal vein. So this part forms the superior vena cava. Okay, then next is the, if I use another color, okay, so inferior vena cava in turn is formed by this is, suppose, the this is the posterior cardinal, then there is subcardinal vein, okay, and there is supracardinal vein. So what happens is, actually this supracardinal vein and the subcardinal vein, you know, there is this azygous vein also, part of it. These are the things, they form the IVC. Let me erase it. Okay. I hope I can. Okay, coming to all this. So the right horn of sinus venosus, it will form the smooth part of right atrium. Left horn in turn form the coronary sinus. Then there is the primitive pulmonary vein. It forms the smooth part of left atrium. The primitive atrium, it forms the trabulate part of left and right atria. There is endocardial cushion, the atrial septum, the membranous interventricular septum, AV and semilunar valve, all like that. There are primitive ventricles. Okay, so it forms the trabulate part of the left and right ventricles. The bulbous cordis, in turn, it forms a smooth part of the left and right ventricle, and ultimately the truncus arteriosus, forming the ascending aorta and pulmonary trunk. These are given of development. Next, there are some postnatal derivatives. So ductus arteriosus forms the ligamentum arteriosum. Ductus venosus forms the ligamentum venosum. Foramen ovale results in fossa ovalis. Allantois, the urachus, forms the median umbilical ligament. The umbilical arteries forms the medial umbilical ligament. Okay, there is difference. This is median and this is medial. Umbilical, medial. Allantois, median. Okay, umbilical vein in turn gives rise to ligamentum teres hepatis. That is a round ligament. Okay, as you know, it contains the falciform ligament. This contains the falciform ligament. Okay, I also didn't know that. So urachus is part of allantois between a bladder and the umbilicus. Okay, so meaning the urachus part is forming. Next we come to the fetal circulation, mainly three shunt. Okay. First is from the umbilical vein to ductus venosus. Okay. So this is ductus venosus. This is the first shunt. Okay. Umbilical vein to ductus venosus to IVC. This is IVC. Then next is IVC to foramen. This is the IVC to foramen oval to left atrium. Here it goes. Okay. So hence IVC takes brings the highest oxygenated blood. Okay, from the umbilical vein it goes here and then to the left atrium. Then from the deoxygenated blood from the SVC, it goes to the right atrium, the right ventricle, and goes to the main pulmonary, the main pulmonary artery. Then by ductus arteriosus goes to the the descending aorta. Okay. It is because there is decrease in increased pulmonary artery resistance. Okay, in fetus. So hence instead of going this side mainly, it goes this side. Okay, this is very resistant. Okay, so it goes like this systemic circulation. So mixed blood, mostly there is mixed blood only. Okay, so when the as this is saying, when the infant takes a breath, there is decreased resistance of pulmonary vasculature. Okay, so what happens, this side and this side, the resistance is decreased. So and also the left atrial pressure is more than right atrium. So like this foramen oval, it closes as we discussed earlier, which is now called as fossa ovalis, and there is increase in oxygen from respiration and decrease in prostaglandin from the placental separation. Okay, so placenta will be supplying the prostaglandin, so there is decrease in prostaglandin, oxygen is increasing, resistance here is less. So ultimately, like, the blood stops going through this, like, it everything goes towards the easier way. So the ductus arteriosus closes. There are some drugs like NSAID, as we said. If there is patent ductus arteriosus, the these NSAIDs, indomethacin, ibuprofen, or acetaminophen, like paracetamol, so they help in closing the ductus arteriosus. It is actually because these NSAIDs, they inhibit the prostaglandin production, so thereby it's accelerates the closure of ductus arteriosus. Okay. So yeah, so the prostaglandin E1, E2, these things keep the PDA open, so inhibiting this hence will close the PDA. Yes, the ductus arteriosus. Next we come to the anatomy of CVS. So we have to know the thoracic part of which um, segment is this? Let me check. Okay. So there is one syndrome called Ortner syndrome. Okay. So Ortner syndrome, it is important because suppose the left atrium is enlarged. Okay, this is the left atrium, and it will lead to the compression of the esophagus. Okay, so left atrium is posteriorly placed, esophagus is here. Okay, so it is, so what happens, it will compress it due to enlargement, there will dysphagia. Okay, and along with it, since the okay, so since the left recurrent laryngeal nerve, the left recurrent laryngeal nerve passes through here, it is also getting compressed, hence there is hoarseness. This is called Ortner syndrome. Okay, so it is a sign, one of the symptom, it can be shown, not in all cases, but in some cases it might show as one of the signs of condition like mitral stenosis, like that. There is enlargement of left atrium. Next, and the right ventricle is the anteriormost part, as you can see, right ventricle. So it is most commonly injured in trauma. Left ventricle is 2/3 and right ventricle is 1/3 of the inferior cardiac surface. Okay, so that also, you know, that's also important. Okay, next we come to the pericardium. Okay, we were talking about the thoracic level of this. So this is probably at the level of T7 or T8, because like there is 4 chambers, all are visible of the heart, so it is actually the characteristic of like T8 vertebra. Okay, so left atrium is actually seen between T5 to T8, the left atrium. And all 4 are seen mostly in T8. So that's it. Okay, so next we come to the pericardium. It consists of 3 layers. Okay, the fibrous, the parietal, and the epicardium. Okay, that is the visceral pericardium, and it is innervated by phrenic nerve. It's important. That's why it causes referred pain to the neck or arms, or one or both the shoulders. Okay, so whenever there is heart attack, we frequently see that here sign as pain in the chest, along with there can be pain in the left side of the arm, okay, or in the jaw. So this is because of phrenic nerve, it is irritated and it causes this referred pain. Okay, next we have the coronary blood supply. let us see how much is left. Okay, there is a lot actually. So we were at coronary blood supply. Like after anatomy, we will end this session, and after some time, let's begin again. So the left, so the left anterior descending artery supply 2/3 of the interventricular septum. Okay, it's important. 2/3 of interventricular septum, anterolateral papillary muscle, and anterior surface of the left ventricle. Okay, so this is the most commonly occluded one, the left anterior descending artery. Important is 2/3 of interventricular septum, anterolateral papillary muscle, and anterior left ventricle. The posterior descending artery, it supplies posterior 1/3 of interventricular septum, then the posterior 2/3 of ventricular valves, and posterior middle papillary muscles, and also the sinus and atrioventricular nodes. Okay. The infarct of this may cause nodal dysfunction, bradycardia of heart block, etc. So yeah, we can, if there is bradycardia and there is sign of myocardial infarction, we can think it can be a PDA occlusion. Next, there is right acute marginal artery. It supplies the right ventricle. Then okay, so yeah, there is one thing. There's something about the dominance. Okay, dominance. So there are two, mainly like three types of dominance. One, right dominant, where the PD arises from the right coronary artery. Okay, so this is the right coronary artery. So if the PDA, if this PDA, if it arises from this this right coronary artery, then it is the right dominant circulation. It is most common. Next is the left dominant circulation. If the PD arises from left circumflex artery. Okay, so this is the left circumflex artery. So if the PDA arises from left circumflex, suppose this is the PDA, posterior descending artery. So if it arises from it, this is left dominant. So it is about 5 to 10% of the patient. And codominant are those in which both this left circumflex and right coronary supply the PDA. It is about 10 to 20%. So this is the codominant circulation is like least likely to have like severe MI symptoms or damage due to like PD or L6 or LCA like occlusion. Okay, so coronary blood flow to left ventricle and interventricular septum peaks in the early diastole. This is important. And coronary sinus runs in the left atrioventricular groove, drains in the right atrium. Okay, so for now, it's in this session. Thank you.